Welcome, doctors. We will start now our presentation with Dr. Yousry. Let's start. Dr. Yousry.
Hello. It's my pleasure to share with you my experience in managing diabetic foot infections. I will give an idea about the diabetic foot and its complications and how the patients are presenting, and how at the end of the lecture we'll give examples of cases which are managed. Surgical management of diabetic foot infection. At the beginning, we'll give some facts about the diabetes and its foot complications. Most of you know majority of this information. Of course, diabetes mellitus, well-known medical problem. It is increasing rapidly in the population. It has two major complications, vascular and neurological, which are the leading cause to the diabetic foot phenomenon. And this will lead to increased risk of ulceration, infection, amputation, and even mortality. The number of the people with diabetes is increasing in every single nation. By 2030, at least 550 million people will have diabetes, which will be approximately 10% of the world adult population. Diabetes kills more people annually than breast cancer and AIDS combined. Quite slow, deadly, expensive chronic disease. Accounts for 75% of our healthcare costs. Seconds are counting. Every 7 seconds, someone dies from diabetes. Every 20 seconds, someone is amputated. And 10 years ago, it was every 30 seconds. Although the campaign and everything we are doing, still it became every 20 seconds. 60–70% of those with diabetes will develop peripheral neuropathy. They are unaware that they have it. Up to 25 of these with diabetes will develop foot ulcer. More than half of the foot ulcers will become infected, and this will require hospitalization, and 20% of these ulcerations will end in amputation. So diabetes contributes approximately to 80% of 120,000 non-traumatic amputation in the United States. After a major amputation, 50% of people will have their other limb amputated within 2 years. More than half of the people with osteomyelitis of the heel will undergo high-level amputation. All these facts, as you see, are pessimistic facts. The relative 5-year mortality rate after limb amputation is 68%. When compared with cancer, it is second only to cancer lung. It is 86%. Other cancers are less. 39% in colorectal cancer, breast cancer 23%, Hodgkin is 18%, prostate is 8%. So mortality rate is very high compared to even cancer. 5-year mortality rate. People with history of diabetic foot ulcer have 48% greater 10-year mortality than people with diabetes alone. 1/3 of patients seeking care for ischemic wounds die unhealed. For people on dialysis receiving an amputation, 2-year mortality is 74%. It's very high. Diabetic foot ulcers double mortality and heart attack risk while increasing risk for stroke by 40%. So it is clear that foot infection common among patients with ulceration and are a major cause of hospitalization and lower extremity amputation. So our role, consequently, is aggressive and emergent surgical intervention. It is essential in the face of life or limb-threatening infection to achieve limb salvage and survival. Severe diabetic foot infection carries 25% risk of major amputation. So we need consistent, stepwise surgical approach combined with sound surgical principles. It is of paramount for successful management of the severe diabetic foot infection. It is not one-man show. It is a teamwork. It is collaboration between medical and surgical discipline. Diabetic foot care team determines if the patient is medically stable for operating room for urgent surgery to control severe diabetic foot infection. We should emphasize on pre-existing conditions such renal insufficiency, coronary heart disease, peripheral vascular disease, congestive heart failure, immunosuppression, in conjunction with readily accessible clinical and laboratory findings when making our decision. Most important among these are the severity of infection based on specific tissue involvement and the presence of systemic toxicity and or metabolic instability. So we need a communication between the surgeon and the medical team to determine the stability of the patient, the risk of infection posed to the patient, and the limb to establish the venue of management. Initial assessment, of course, as all of you know, history. History is very important to know everything about the patient. Physical examination to determine the patient's overall medical condition. We focus on evaluating extent of systemic response to infection by determining the patient having fever, rigors, nausea, vomiting, hypotension, unexplained hyperglycemia, tachycardia. The blood investigation, serum chemistry analysis, hematological testing are reviewed to assess the metabolic state of the patient. To examine the foot, we need to include the history. In general inspection, we have to check the patient foot and the shoes. Why the shoes? Because sometimes it is the cause of his main problem. Many times we remove the shoes and we find the foreign body inside, nail, any foreign body inside. Sometimes the foot is very tight, not suitable for the patient. Skin of the patient, you have to check. Muscles, musculoskeletal system has checked. Neurological assessment, vascular assessment. As we know, the neurological cause, neuropathy and ischemia are the main two factors causing diabetic foot syndrome. And then we can classify the risk state of the patient after that. So the surgeon, when he sees the patient, he should palpate for the presence or absence of pulse, femoral popliteal pulses and pedal pulse. And we should observe signs of ischemia, necrosis, and the gangrene should be noted. We have to determine the extent of the tissue involvement because it is important to see if this limb can be saved or not. The surgeon should inspect the bride and probe the wound to determine the presence of muscle, tendon, bone, or joint involvement. Sometimes the wound is looking innocent, but it has a deep connection, so we have to check for sinus tract and abscess. Deep tissue infections can be limb-threatening or even life-threatening. It will appear superficial bully. It is not innocent thing when you find superficial bully or petechiae or ecchymosis. These are signs of deep infection. Fluctuance, soft tissue crepitus. When you press, you find the pain on palpation, and the patient before was having neuropathy, this means that he is having deep infection. Physical examination of the entire lower extremity, it is very essential to determine the proximal extent of the infection because the foot infection is spreading to the leg. You have to check also the leg and the extent of the infection. Radiographs are obtained to determine the absence or presence of osteomyelitis, gas and soft tissue, and the foreign body. We should take blood culture to obtain the initial assessment of the patient if there is bacteremia or pharyngeal sepsis. Culture taken also from the wound. It will be taken better in the operating room to take deep tissue specimen under a sterile condition. And we open the culture tube immediately before we take the sample. Swab culture, we can take it initially, but there is debate about its usefulness, but still it has a role in management. So neurological assessment, we have to see the patient is having respond to the touch, foregram monofilament. Also, there is deformity. We have to check for deformity, limited joint mobility, if it is there or no, and since how long, and if there is the signs of Charcot Foot, midfoot or ankle, hot, red, swollen. Swollen, say one limb swollen with hotness and edema and no pain. This is an early sign of Charcot Foot. We should pick the patient before it becomes a fracture. Is there any malalignment or gait analysis or no? Then we have to also check the blood flow in the limb. Vascular workup, it consists of non-invasive and invasive studies. we delay it until infection is adequately controlled through urgent surgical debridement. So the primary step is surgical drainage and debridement to control the infection. Vascular surgery and endovascular intervention is not visible or beneficial to the patient with severe or life or limb-threatening infection until we control the infection through surgical debridement. But this doesn't mean that we'll postpone it for a long time. It should be, vascular surgery should be consulted as soon as possible, especially in the face of skin, to reach consensus on treatment plan and to perform any needed revascularization early after the initial treatment plan. To perform any needed revascularization, it should be early after initial surgical debridement, as soon as you can. So for patients with severely infected dysfunctional foot, it's preferable to perform revascularization within 1 to 2 days after the initial surgical debridement. In many circumstances, there is long time span between debridement and revascularization. In some centers, they are doing revascularization, and there is long time span between revascularization and the surgical intervention. And this will lead to more tissue loss and maybe limb loss. Antibiotic treatment, we start empirical treatment, of course, after checking the general condition of the patient, clinical appearance, the odor, antibiotic susceptibility of organism in the specific hospital you are working in. For severe diabetic foot infection, initial antibiotic therapy should commence with parenteral broad-spectrum antibiotics that have activity against gram-positive cocci as well as gram-negative obligate anaerobic organisms. Definitive antibiotic therapy is based on culture sensitivity results from the deep intraoperative cultures along with the patient's clinical response to the empirical antibiotic therapy. So when I have the culture report in my hand, I should check, is the patient responding to my empirical therapy and it is matching what is happening, what is in the culture report or not, and according to I decide. Consideration should be made choosing the safest antibiotics that is most convenient to administer, given that treatment may last for 6 weeks or longer. Antibiotic choice, if it is mild infection, oral antibiotics that cover skin flora, including streptococci, staphylococcus aureus. Agents such as cephalexin, dicloxacillin, amoxicillin, clavulanate, clindamycin are effective. If it is MRSA, we can use clindamycin, trimethoprim, sulfamethoxazole, minocycline, or linezolid. If gram-negative aerobes or anaerobes, we have to do dual drug treatment. We have trimethoprim, sulfamethoxazole, plus amoxicillin, clavulanate, clindamycin, plus fluoroquinolone, such as levofloxacin or moxifloxacin. Moderate to severe infection, patient, it is better, of course, to be hospitalized for parenteral antibiotic therapy. And the empirical choice should cover streptococci, MRSA, aerobic, gram-negative, bacilli, and anaerobes. We cover MRSA by vancomycin, linezolid, or daptomycin. Acceptable choices from gram-negative aerobes, aerobic organisms, and anaerobes include ampicillin, sulbactam, piperacillin, tazobactam, meronym, and ertapenem. Alternatively, ceftriaxone, cefepime, levofloxacin, moxifloxacin, sterinam, plus metronidazole would be effective, sufficient to cover aerobic, gram-negative, and anaerobic organisms. Severe diabetic foot infection always requires surgical intervention to control infection that may be life or limb-threatening to the patient. The surgeon operating on severe diabetic foot infection must be knowledgeable of the anatomy of the foot along with the pathophysiology of ulceration and infection to track the spread of the infection and open the pockets. In most instances, the surgeon should be experienced in the surgical management of diabetic foot infections to prevent failure of surgery and higher amputation. During surgery, it is important to begin with detailed wound exploration. You have to check the wound. Where is the spread? Where is the pocket? How much destruction? That includes removal of all sloughed dead skin and the opening of sinus tract to establish the tissue planes and the compartments of the foot that are violated. Foot is having compartments. You have to open the compartments which are affected to drain it and decompress to prevent more tissue damage. The surgeon can now determine the portion of the foot that needs to be amputated or widely excised to adequately control the infection. In many instances, we see limited incisions, small incision. It should be avoided because it is not doing the proper management. Although it will do decompression at the beginning of the infected area, but all non-viable and infected tissue and bone will be left down. We should remove everything. We should excise any necrotic tissues. So it needs to be excised during the initial debridement to enable wound healing. Exposed tendon should be excised to prevent further tracking of the infection. After adequate surgical debridement, the wound is then irrigated with large amount of saline to reduce the number of bacteria present in the wound. Then we kept it open, we don't suture it. The open wound is packed with moist dressing followed by dry dressing. The goal is to maintain moist wound healing environment. Dressing usually changed daily, beginning 24 to 48 hours. If it is severe infection with high output to discharge, but it can be every 2 days or 3 days if the infection or the size surface area of the wound is not large. Diabetic foot is never managed from single debridement. Usually it needs multiple sessions of debridement. So repeated debridement should be performed as needed to control the infection, as well as we can use the negative pressure wound therapy to control tissue edema and help in wound bed preparation through encouraging granulation tissue formation. Soon after the initial surgical debridement is when non-invasive and invasive vascular studies are performed, as we said. So we consult the vascular surgeon if we to do the vascular study to check if he is ischemic and needs vascular intervention or not. We have various angioplasty, we have various forms of stenting. Endovascular atherectomy are valuable means of minimally invasive forms of revascularization that can be followed, if unsuccessful, by distal arterial bypass. Our peripheral arterial bypass has been shown to be beneficial procedure for salvage of ischemic diabetic limb with considerable tissue loss. Now, after we control the infection, we restore the blood flow, we need to obtain a long-lasting wound closure after surgical debridement to control the infection, because we have large area of tissue loss, we have extensive tissue loss. So soft tissue reconstruction can only take place when infection is eradicated. You cannot put graft on necrotic or infected tissue. So non-viable tissue should be removed. Everything, all bone completely removed, excised. Arterial perfusion is sufficient. So to start the reconstruction, you have to have healthy tissues. Numerous techniques are used to obtain wound closure in the diabetic foot, and the procedure chosen must be tailored to each patient and circumstance to obtain soft tissue coverage that is durable and mechanically sound. Simplest and least invasive modality should be used first when it is visible. The surgeon first should decide is it possible to do primary closure under minor minimal tension or not, after revision of the debridement or limited pedal amputation. If it is not suitable, and in most cases it is not suitable for primary closure, especially if the wound is high output drainage or extensive tissue loss. So we manage it by the simple dressing, wet to dry dressing, in addition to negative pressure therapy to facilitate granulation tissue formation. In many complex wounds, plastic reconstruction surgical techniques are later used to achieve wound closure. If we follow these things, we can optimize the likelihood of limb salvage. The goal of limb salvage is to provide the patient with a limb that is stable, mechanically sound, and resistant to further skin breakdown, while resuming an ambulatory status. Patient usually is having tissue loss, so he will need custom shoes, or sole inserts, or bracing are used post-operative to assist in achieving this long-term goal. Unfortunately, a severe foot infection is often the wake-up call to the diabetic patient who didn't comprehend previously the severity of the disease. Finally, the patient has to be better educated to understand the disease and to prevent further diabetes-associated complications. We have to keep in mind that diabetic neuropathy is the main cause associated with majority of food problems, as due to diminished or absent sensation. Minor injuries will pass unnoticed, leading to delayed presentation, which will lead consequently to more tissue loss, morbidity, and even mortality. Patient is not feeling wearing tight shoes, doesn't feel trimming his nail, injuring himself, putting his foot in hot water or using hot compress for a long time causing burn, sitting near the heater causing burn. All these things because of loss of sensation. We have to diagnose the patient early to prevent reaching this phase so that we can prevent the diabetic foot complications or at least reduce them. This fact should encourage us to screen all diabetic patients, especially newly diagnosed for neuropathy, and start its treatment in early phase with patient education, which will lead to early presentation and consequently less foot complications. This in brief, how to manage diabetic foot in a theoretical point of view. Now I give you some practical examples of the cases which will also show you how the patient is presenting, because it is delayed presentation due to neuropathy, loss of sensation, and also sometimes due to the delay, improper management. This is one patient who presented to our center. He's having gangrene, as you see, extending from started in the fifth toe and extended to the whole foot reaching to the heel. And then the decision of foot amputation because it cannot be managed. If such a patient, we pick him from the first moment and did toe amputation, it will not spread like this. So, of course, we diagnose the patient, we evaluate his general condition, control the infection, systemic complications, diabetes, and we did surgical debridement. It is not only one session, of course, it took many sessions. Still, the tissues are not looking good. We are still doing debridement, but we don't lose the hope. Still, if you look at this foot also, you will say, no, it is hopeless. But still, you have to do your job, and you'll find that the granulation tissue will appear after you do several sessions of debridement. Now the granulation tissue is starting to cover the whole wound. The whole wound is covered now by granulation tissue, and there is epithelialization. Gradually, it is covered by skin and complete healing. Other case, this is another example of the neglected case. The second toe is having gangrene, and some doctors having the idea that diabetic foot gangrene is dry gangrene. Diabetic foot gangrene is dry at the part which is necrotic and dead, but the junction between the healthy and dead tissue is wet, and this is the spread. So as you see, it is spread from the toe along the tendon sheath, both dorsally and plantarly, to involve most of the foot. And it became not only limb threatening, it became life threatening because this patient is presenting with toxemia. So either you do amputation, major amputation, and the patient will lose his limb, or try to drain and control the infection. So we drained and we controlled the infection and the general condition of the patient. And gradually the granulation tissue started to form to cover the whole wound, and now it is cured. Another case, this is heel gangrene, and early in the lecture you know that there is very high percentage of limb loss in heel gangrene with osteomyelitis. So we have to interfere very fast and very aggressive. With good debridement and adequate care, patient limb was saved. Ankle joint deep infection, of course, this is in these cases we have to do debridement and we have to use negative pressure wound therapy because the joint space, the pus will trickle inside and you cannot control the infection. And it is cured. This is Charcot Foot, as you know, and it has mid-sole ulcer. With the proper care, it is cured. Since we have to offload the limb, we have to offload the ulcer area, otherwise it will never heal. It will become more deeper and more complicated. Big toe infection, which was managed and then decided to amputation, and with the proper care, it was healed. Another, this is an example of the small incision, as I told you in the lecture. This is spreading infection across foreign body, and the infection spread to the whole foot. So we made multiple small incisions, which are not sufficient to control the infection. And then the infection caused general symptoms of toxemia, and the limb was about to be lost. You have to make generous incision, you have to do proper debridement and drainage, and the limb is saved. This is the first MPJ, and the second toe there is infection and ulceration, and with the proper care it is managed and cured. Another Charcot Foot case, it is not managed in the proper way, and we should take care of excising the skin. It is diabetic foot. Excising the skin will not solve the problem. You have tissue loss, and you are in a problem in the future to reconstruct the skin. To replace the lost skin, you have to minimize removing the skin. You have to dig deep. After managing, it is cured. Another case of infection in the foot due to foreign body also, and generous incision, proper debridement with minimal, with preservation of the skin. You should take care of the skin. Another case of ankle joint infection. Of course, you have to use cast for these cases to prevent the fracture or to prevent the loss of the joint function. After management, it is cured. Another severe case of infection, as you see, it is not managed. Only small incision in the medial side of the foot, and the infection, as you see, it is in the toes area started. It should be, the pus is pouring. This is us telling you, open, drain me. This after proper management, it is cured. Another case of neglected gangrene. It is dry gangrene, keep the toes to auto amputation. Infection will not wait for us for auto amputation in diabetic patient. Gangrene will spread, as you see, and will cause life or limb threatening infection. Also another case, this was ischemic patient, and it was done for him amputation of the big toe, and the wound became like this. He told him, we need to cut the leg. It is better to correct the cause. The cause was ischemia. We corrected the ischemia, did angioplasty, and we treated the wound, and he was saved. Another case, as you see, the infection, the foot became properly, and then since when it is mute?
Just now.
This is another case. Sorry, it was mute. I don't know if you heard this. Another case of gangrenous ulcer, and you should take care of in any ulcer in the leg, whatever, even if it is very superficial, you have to remove the gangrenous tissues because it can reach the tibia, if especially if it is on the anterior surface, and it can lead to amputation. Another case of gangrene in the heel. We should not wait until the heel becomes gangrenous in this extent. It starts usually in a bedridden patient with only erythema. We should offload the ulcer, the heel from pressure, because this pressure will lead to ischemia and gangrene. And once it happens, we should remove the necrotic tissue. We should surgically debride and offload the area. And if it is ischemic, we should control ischemia. Thank you very much.